Loretta Tayo. I'm from the Philippine General Hospital, and I'm here to talk about simulation as a patient safety training tool for the anesthesiologist. So anesthesia is regarded as a leader in patient safety and serves as a model for improving safety in healthcare. One important reason anesthesia took a leading role was the early realization that the manner how anesthesia delivered profoundly affects safety, patient safety. So the delivery of anesthesia is actually a long process. It starts from preoperative evaluation and anesthetic planning, the induction of anesthesia and airway management, monitoring and maintenance of anesthesia during the procedure, emergence from the anesthetic, and finally, post-operative care. So in effect, efforts at improving safety in the field focus largely on the process by which anesthesia is delivered and therefore the way anesthesia as a specialty is taught. So anesthetic mortality has significantly decreased from 1 in 1,500 cases in the 1950s to as low as 1 in 250,000 in healthy patients due to our efforts to reduce patient mortality and morbidity. The previous two speakers have talked of efforts and system changes that have occurred that has improved anesthetic delivery and therefore patient safety. So some of the established tools for safety, safety improvement include technology and equipment as discussed by Dr. Oracion. It includes anesthetic delivery systems and monitors, organizational changes including establishment of guidelines, standards, and checklists, integrating concepts of systems thinking, like Dr. Nieto discussed, including the SVAR, root cause analysis, and changes in education development, which includes system-based education, which is what I will talk about. So this morning I'll be talking about how simulation is used as a training tool to improve patient safety in anesthesia. I'll go over the rationale of using simulation in healthcare, its history and evolution in anesthesia, and how it is applied to our field today. So the pursuit of patient safety involves reducing the gap between best practice and the care actually delivered to the patient. Understanding how to reliably deliver best practice care using established anesthetic techniques may today be more important than seeking new ones. A growing body of evidence shows that clinical skills acquired in medical simulation laboratory settings translate directly to improved patient care practices and better patient outcomes. So simulation is used to bridge between theory and practice. So as we all know, clinical care's information application is always a collaborative event. Dr. Nieto stressed the importance of teamwork, and of course, it is a collaborative event between the anesthetist and the patient. So changing oneself into a clinician is a significant challenge. Reality, actual patients in clinical settings have served as the training ground for generations of anesthesiologists. With simulation, the clinical setting is no longer the only place to train physicians. So what is simulation? David Gaba, who is considered a pioneer in simulation in anesthesia, emphasizes that simulation is a technique, not a technology. So simulation in medical curriculum means recreating or imitating part of some clinical scenario for purpose of training or evaluation. So conducting simulations in the clinical environment can be justified by a number of rationales. These include everything from training efficiency to the underpinnings of adult learning theory. So Kolb's experiential learning cycle illustrates why simulation is an effective tool in clinical education. So during simulation of a clinical scenario, a concrete experience, either a new one or as a past, a reinterpretation of a past experience is encountered by the participant. So actually, for anesthetists, the main advantage of doing simulation is recreating clinical events that are uncommon in our practice, but that can happen. You know? So during the debriefing, the participants are able to review or reflect on the experience, and they're able to conclude and learn. Actual experimentation in the clinical setting means to being able to apply these learned experiences to actual patient care. So the use of simulation for education and training started in the aviation industry in the 1929 when they first developed the pilot maker, which is basically a blue box equipped with a cockpit and controls. The use of simulation in medical education can be traced back to the medieval time. In the 18th century Paris, when they used an obstetric mannequin called the obstetric phantom, which is actually made of an actual human pelvis and a mummified dead baby, to practice or teach vaginal delivery. So the first ever simulator used in anesthesia was Lairdal's Resuscian, which is a task trainer. It was a simple model designed to teach cardiopulmonary resuscitation. The first true moderate to high fidelity model in anesthesiology is made in the 1960s, which was SIM-1, the world's first computer-controlled interactive simulated patient. It's a 6 feet 295-pound android that breathes, has a heartbeat, it blinks its eyes, and can open and close its jaw for airway management. So it was never manufactured commercially because of the sheer bulk. The computer was big, the mannequin was too big. The Harvey cardiology mannequin can simulate up to 27 cardiology events. As the mathematical models of physiology and pharmacology became clearer, computer softwares were developed to simulate the normal human response. In 1987, it was Dr. David Gaba and his team in Stanford who created CASE, or a comprehensive anesthesia simulation environment. That one. So they combined waveform generators and vital signs monitors, and they were able to manipulate vital signs to create critical events. So at present, there are actually more than 80 commercially available simulators for use in anesthesia. So they are classified based on three categories: the mode of interaction, whether it is screen-based, hardware-based, or virtual reality-based; the physiological model used, or how mannequin patient simulators models an actual patient, and it's used to whether it's used to teach psychomotor or cognitive skills. The price range, sad to say, is anywhere between 100 to 50,000 US dollars. But recently there have been free software for simulating um, patient vital signs that can be used to teach or to simulate anesthesia events. So having discussed simulators, I'd like to emphasize that simulation is not about the technology. So a high-tech simulator doesn't equate to a realistic clinical scenario and therefore doesn't necessarily give a richer training experience. So fidelity in simulation is seen as a conceptual or experiential, and in this view is often separated from technology. So simulation fidelity refers to the realism of the entire scenario as viewed by the learner. So there are three parts of simulation fidelity. You have physical fidelity, how real the environment is. So the highest fidelity for any critical event in anesthesia would happen in the operating room. Conceptual fidelity is how real the case scenario is. So or how relevant the case scenario is to your trainee. So if you're, say, training a first-year resident to deal with malignant hyperthermia, the concept might not yet be that real for that trainee. If you're training a third year for malignant hyperthermia, then that might be more real or of high fidelity for that training. So the important thing is to maintain a balance between simulator technology and simulation fidelity. So if you want a scenario to be as real as possible for your patients, then choosing the right form of simulator. For instance, you'd like to simulate pre-anesthesia evaluation. Then you don't need a very high-tech simulator. You can use a standardized patient or an actor to teach your resident or your trainee how to do preoperative evaluation. So it all depends on your